Hello, and welcome to this episode of In Discussion With from Medical Update Online. Today I'm talking to Professor Cathy Harrison, Chief Pharmaceutical Officer for Northern Ireland, and we're talking about implementing innovative clinical pharmacy services across a whole health system. Could you start by introducing yourself?
Hello, my name is Professor Cathy Harrison. I'm the Chief Pharmaceutical Officer at the Department of Health in Northern Ireland.
And can you give us a brief overview of your role, what your current job involves?
I am one of four Chief Pharmaceutical Officers in the UK. We have one in England, Scotland, Wales, and Northern Ireland. And in my role, I am the most senior advisor to government on pharmaceutical matters and also the head of the pharmacy profession in Northern Ireland. And I have responsibility for medicines policy, and that includes pharmacy practice, medicines access, medicine safety, innovation, e-pharmacy, and pharmacy workforce and medicines efficiencies. And the Chief Pharmaceutical Officer role is an established leadership role. And within our Department of Health, it has been in place for over 30 years. And a very important part of my job is to work with the other chief professional officers, such as the chief medical officer and chief nursing officer. And we work very collaboratively to consider how our professions can best engage and deliver on the priorities for our patients and population need and our health service.
Now, you recently gave the keynote address at the European Society for Clinical Pharmacy annual symposium, and you described how clinical pharmacy is making a meaningful contribution to health and social care services, and you offered some insights as to how this had been achieved in Northern Ireland. And this is what I'd like to explore in a bit more detail. But first, could you give us a bit of background information, the policy context, if you will?
So, in terms of context, I think, first of all, I would say I think Northern Ireland is probably similar to a lot of other countries across the UK and European, and maybe further afield as well today. So, we are experiencing a demand for medicines that is rising, and that is related to our increasing and aging population. And we also have persistent health inequalities here in Northern Ireland. We have medicines costs that are rising annually and represent actually our second highest costs in our health and social care economy after staff salaries. And we also are benefiting from enormous advances in medical practice and in pharmaceuticals, but that is coming with a high cost and quite a burden for our health service in relation to implementation. We also know, and we are experiencing I suppose, the downside of high medicines use, and that is that we know high medicines use is associated with an increased risk of avoidable harm and also adverse outcomes for our population. And we also know that, and I suppose we have an increase in awareness that medicines are now also make up 25% of our carbon footprint within our health and social care system, and that our medicines waste is becoming a lot more awareness of the difficulties around that and the negative effect it has on the environment. Now, really, to close off that in terms of the broad policy context, although we have tried and tested practices in place in relation to patient safety and also cost effectiveness, the challenges are growing and continue. And so that we do need to keep a strong focus on those areas and how pharmacy can contribute to it.
Hmm. So, what does this mean for clinical pharmacy?
I would say that we have been on a bit of a journey in Northern Ireland over the last 8 years, and that is after some work that we undertook around 2016 to really understand our challenges around medicines, and that led to the development of a new strategy that we called our Medicines Optimisation Quality Framework. And that strategy, for the first time, really looked at how we use medicines, what our challenges are, and also it identified as one of our key challenges the high level of variance in how medicines were used across our system and how we needed to move to more standardized ways of practice. And for the first time in that strategy, we actually describe what a patient can expect when they have medicines included in their care in the key healthcare settings of hospital, general practice, community pharmacy, and in care homes. And that really, I suppose, for the first time as well, allowed us to think about how would we affect change across a whole system and how pharmacy could contribute to that, and in particular, how we could translate our already quite strong evidence, even then to 8 years ago, of clinical pharmacy practice in hospital across a system.
Mm, mm. There must have been more to this, other developments to support what you were doing. So, what sort of things were going on in the background?
Over the last 8 years, we've had a number of huge sort of reform programs going on to support that strategy. And one of the most important one was in relation to workforce. Because when we started to look at our workforce, and this would probably have been around 6 or 7 years ago, we were in a position that we did not have sufficient pharmacists in our workforce to deliver either our current levels of care or certainly to deliver on our ambition in relation to medicines optimisation. And that led to the development of a new pharmacy workforce review. And some of the key challenges that we had to address there very quickly were that reports at that time that our interest from our university applications for pharmacy, for example, were down. There was a lot of competition at that time for pharmacists, budding pharmacists and many of our young science students were going into IT at that time and had moved away from health, for example. And we also had no significant clinical pharmacy practice outside of hospitals at that time. So that led to our development and publication of a pharmacy workforce review that we did in 2020. And that allowed us to really focus on a number of big areas of work. And the first thing we did was we focused on attract, recruit, retain, which is really around increasing the capacity in our workforce, a dedicated attempt to reach out to schools to promote pharmacy as a very good career, and also invest more into the training programs for our existing pharmacists to upskill more independent prescribers, and also think about advanced practice and how that would be developed as well as consultant pharmacists. And in addition to that, to invest in new roles in general practice and also in consultant pharmacist roles in hospital, and to begin to develop more clinical services in community pharmacy.
Mhm. And did these pharmacy workforce developments also have implications for education and training?
There was also a big focus on reforming our undergraduate degree and our foundation year. So the first 5 years of pharmacist training. And that has to introduce much more clinical training into our undergraduate degrees, and also to embed independent prescribing into our foundation year training. So that sort of hopefully sets a bit of the policy context in terms of the macro level, and also then what we did in relation to medicines optimization and how that translated into clinical pharmacy.
Now, could you tell us in a nutshell, where is clinical pharmacy in Northern Ireland now?
Today in Northern Ireland, we have a skilled and growing clinical pharmacy workforce, and they are available to take on the new and advanced practice roles that we really are aspiring to through our strategies. Now, that workforce really is offering faster access to care and services, and so helping to increase capacity within our health and social care, which is one of our key challenges. They're also driving improvements in the safe, appropriate, and cost-effective use of medicines in both primary and secondary care. and optimizing the outcomes for patients. And they're connecting individuals with their essential medicines and offering professional advice and accessible clinical services to treat and prevent illnesses in our community pharmacies.
That's really very impressive. And of course, this includes a large number of prescribing pharmacists. How many exactly?
In Northern Ireland, we have approaching 30% of our pharmacist workforce would be independent prescribers at the moment, and that's growing. And we commission around 150 independent prescribing training course places a year. And that's for our current pharmacist workforce who are already on the register. But in addition to that, from 2026 onwards, all of our new registrants will come out of university and come out of their foundation training year as prescribers with an independent prescribing qualification. And that means we estimate that that is going to increase our number of prescribers in Northern Ireland up by a further 1,000 by the end of this decade. So we're going to have see a tremendous acceleration really in the number of prescribers now in the coming years.
As I said, it's an impressive list. Everyone wants to know how you got the funding to do so much. How did you do it?
So the funding that we secured for improvement and for advancement in pharmacy practice in Northern Ireland didn't happen overnight, and it didn't all happen at the same time. It was really truly incremental, and it involved some small scale investments as well as some very large investments that we managed to secure. And for example, in general practice, we started off in general practice with a small number of pharmacists working in different general practices in sort of legacy roles where they might have been offering prescribing advice. It wasn't a structured employment model, but we started off quite a number of years ago now, I mean, probably 10 years or more, by piloting some more strategic approach to if you place a pharmacist in that environment and then evaluating their impact. And we also commissioned some formal research on the role of general practice pharmacists and their value. And of course, we were doing that at a time when there was a lot of interest in the role of general practice pharmacists across the UK. So other academic institutes were doing the same thing as well. So then in policy, and with me and my team in policy, we were able to look at that evidence both locally and nationally and say and put together and support business cases for a much bigger scale up of general practice pharmacy. And from 2015 to 2020, I have to say that our commissioners secured sufficient funding to provide every general practice in Northern Ireland with the equivalent of a full-time general practice pharmacist. So tremendous investment, but it started small, build the evidence base, and then scale up and win over the funding. It was a substantial amount of money, and they're fully funded posts. But an important part of that, of getting that business case approved, was that it was approved on an invest to save basis. So that meant that we had to put a case was put forward whereby these pharmacists in those roles would provide benefits financially, as well as in terms of patient safety, and also in terms of other benefits for the practice around freeing up time for the medical colleagues and general practitioners, for example. So an evaluation formed part of that project and part of the business case. And I'm very pleased to say the evaluation did show tremendous benefits and actually it showed that we had a good return on investment, and it also developed that. So in terms of that shows, start with a pilot, look at all your research as well, develop the business case for a larger scale up, but still an emphasis on evaluation and, because it is a significant investment in that one.
Very interesting. So that's general practice. Has this approach also been applied to other sectors?
Other areas as well where we've had success in community pharmacy, we have been able to expand investment in that sector, particularly in our clinical service, and that is through our Pharmacy First service. And this is a service that allows members of the public to seek advice for a range of common illnesses, as well as contraception and urinary tract infections, and now sore throats as well. And they can visit the pharmacy for an assessment and treatment if needed, without the need to go to see a general practitioner. And that is allowing community pharmacists to really develop their clinical skills, and that service can run either as a prescribing service or through the use of patient group directions where needed. And that service we have been building up, and we intend to build up further, and we're doing it incrementally. And again, we're taking the same approach: pilot an area, evaluate it. For evaluation, we use the Medicines Optimisation Innovation Centre, which is an innovation centre that is commissioned by the Department of Health. And they provide a very robust evidence base that is then used to inform business cases to take to commissioners, because it's competitive. We have to prove that these services will have an impact, and they will have a beneficial impact. And we've got a very effective approach to service development and community pharmacy now that has developed over recent years, and a really effective innovation pipeline there. But that's two examples of how we've had, we really have had good success in getting money into the sector.
How does the medicines optimization quality framework fit into all this, or all that you've described?
The medicines optimization quality framework was really our first sort of look strategically at the role of pharmacy in terms of their impact on medicines in its wider sense. Up until it was published in 2016, really our pharmacy practice policy was very focused on settings. So we would have been focused very much on community pharmacy and what they could do, hospital pharmacy, what they could do, that sort of thing, rather than whole system impact and the whole system and the benefits of adopting a complete approach to medicines optimization. And really, I really do think it was a paradigm shift in how we perceived our value and the role of pharmacists within the health and social care system, in general, as opposed to within our own silos and within our own individual services, which on reflection, I think that's probably what we had been doing up to then, and also the difference that made was quite significant, because it meant that the impact that we could see for improvement here was whole system, and it became much more relevant to many, many more stakeholders than perhaps our previous focus, which would have been very much on improvements and developments within our own sector.
Useful perspective. You mentioned championing belief and pride in pharmacy. Why is this important?
Well, belief and pride and championing that in the pharmacy profession is really important, I think, for several reasons. And firstly, it really enhances our professional identity and purpose, and reinforces our important role in healthcare. And that is important to say. It's important for us to say that, and for leaders in pharmacy to say that. I think championing that can really be motivational. I find that has had great value, and that pharmacists do need to hear, and the wider pharmacy team, of course, do need to hear that their role is valued, that they're seen, and that their expertise is acknowledged. And also, it advances the profession to others, and that can be by inspiring our young people to enter the profession, and it can also, support our existing workforce as well, to think about how they think about themselves in terms of their own development and what opportunities may lie ahead for them. Importantly, I think it also recognizes that we're sort of all in this together and that sometimes working in pharmacy is really hard work. It's challenging. Many people are working with heavy workloads, and we have an increasing level of responsibility that we're expected to carry. And finally, I just think someone and people championing and develop and supporting pride and belief really sends a strong message to other professions as well and the public around a sense of pride in ourselves and in our professionalism.
In Northern Ireland, you have the Medicines Optimisation and Innovation Centre, MOIC, as it's known. How does this help?
So the Medicines Optimisation Centre is an innovation centre that actually sits within our health and social care system, and it's hosted by one of our hospital trusts. And it was established almost 10 years ago now to support the implementation of the Medicines Optimisation Quality Framework. And it's funded by the Department of Health and it's commissioned by the Department of Health. And that's through myself and my team. And since it has been established, I have to say it has been absolutely instrumental in supporting both policy development and policy implementation for us in medicines optimization and some of the major advances that we've seen in pharmacy practice. I am able to commission we call it the MOIC or the MOIC fondly. I'm able to commission the MOIC annually to conduct certain pieces of research to support policy development and also to review certain aspects of policy. So, for example, they did some very important work for me post-COVID in relation to reviewing the role of pharmacy during the pandemic. And they also conduct very important research evaluation, of our services. As we are investing in services and running pilots, they will evaluate that and they will get involved right at the beginning in the design of those evaluations with the commissioning teams, and they will make sure we've got really robust evaluation framework. And that's really, really helped us with commissioning, and we've got a very good system for that now that MOIC are embedded into. MOIC have also helped us to secure funding from external sources to health, and this is also really important because it's very, very difficult to get funding into pharmacy all the time. It really is. We have to, I said, it's competitive. We have to put our bids in with everyone else, and sometimes the answer is just simply no. And so we don't really like to take no for an answer. So one of the reasons why MOIC is so useful and why we work so well with them is that they're able to secure funding. It could be from UK research institutions, it could be from European funds, and also through other collaborations. And they've been really successful at that. And that has also, I suppose my final point is that has really allowed MOIC as well to build tremendous collaborations with academia, with industry, and also with our wider health and life science ecosystem in Northern Ireland, and also raise the profile of Northern Ireland internationally and working with some fantastic international partners.
Now, my notes say that your initiatives have resulted in cash releasing savings of £20 million per year, and that gets attention. Could you say a little more about this?
So one of our reform programs under medicines optimization relates to the cost-effective use of medicines. And we have a program that we call the Medicines Optimization Regional Efficiency Program, or MORE for short. And that program over the last 8 years has actually delivered in the region of £200 million of savings in medicines costs for our small health system in Northern Ireland. And that does get a lot of really good attention for pharmacy. And how we've done that is we've designed a program that involves our most senior pharmacists and finance colleagues working together to really understand how cost-effective prescribing policies and their full implementation and consistent implementation and really robust and consistent approaches to procurement of medicines can deliver efficiencies. Now, I have to say that we built the MORE program on very firm foundations of good clinical of a pharmacy clinical effectiveness program. So we have built on that, but we do continue to deliver savings, and it's a very compelling issue to include in your business cases that you can save the system money, and that money is cash releasing as well, which for those of you listening, you'll know. If you know, you know why that's important. Thank you.
Hmm. Now, cynics might argue that the pre-existing system must have been very wasteful, and so it was easy to show savings. Can you reassure us on that point?
No, this is additional. So we had already, prior to the MORE program, we already had introduced generic prescribing, for example. We'd introduced a lot of standardization around procurement practices, but the MORE program really allowed us to take a step change and create more system-wide buy-in for those policies. And and I think that that's why it has continued to deliver consistently.
I understand that you are extending clinical pharmacy services into general practice and community pharmacy. Could you tell us a little more about this?
During 2024, earlier this year, we we in the Department of Health actually published two separate strategies for relating to pharmacy practice. And the first one was a strategy for general practice pharmacy, and the second one related to community pharmacy. And in the general practice pharmacy strategy, the key goal really is to develop the clinical pharmacy workforce in that setting. So we already have pharmacists working in all of our general practices, but really the value that they're bringing to that multidisciplinary workforce has been recognized to such an extent, and through our evaluation that I mentioned earlier as well, that now we're in a position that we want to seek further investment to introduce a full pharmacy team within general practice. And that would have a mix of skills. So that would have ideally a pharmacy technician, the pharmacist, and also an advanced practice pharmacist roles as well. And in that, through that strategy, really, we did set out very, very clearly that we believe there would be great value in a pharmacist becoming the clinical lead for medicines within general practice and within each practice. So that's a significant statement that we've made, and for that actually we have the support of general practice, because we co-produce the strategy with general practice and pharmacy and other stakeholders. So that's sort of one of our major I suppose achievements this year was the publication of that very positive strategy. Now, the second one is in community pharmacy, and clinical pharmacy and community pharmacy, I suppose, is less well understood what we mean by that. And really in Northern Ireland, I am seeing that we will take a sort of phased approach to this. And at the moment, we have already got an established Pharmacy First service, which is allowing pharmacists to address the needs of the public without the need to go to a general practitioner, and for a range of conditions. And I'm very keen to increase the scope of that service and to increase its clinical impact. And in that community pharmacy strategy, I suppose our first goal is to increase the range of clinical services that will be available through community pharmacy. And an important part of the evaluation that we do in this sector as well is to demonstrate that we are able to shift work from other sectors towards community pharmacy, and that is creating capacity within our wider health and social care service. And I'm very keen to do that in clinical services in the future, and also knowing that in this sector we are going to very soon have a large number of independent prescribers in that sector in the future. So over those two strategies in Northern Ireland, I suppose what we are doing really is we are really translating clinical pharmacy from our traditional hospital clinical pharmacy and what we understand in that setting across the system into general practice and community pharmacy.
Mm-hmm. And what next for pharmacy in Northern Ireland? Where do you go from here?
So in Northern Ireland, of course, we have further ambition. And certainly from my perspective, there's a number of areas. I've just chosen three that we are either already moving into or we plan to very soon. And the first one is we will be placing a big emphasis in the coming years on how we make the most of this independent prescribing skills within our workforce. And we'll be looking at that across all sectors. And we aren't assuming that they are being fully utilised, as well as they can be in any sector at the moment, and not even in hospital or in general practice, let alone community pharmacy. So that's going to be a big area of focus, and I know there's a lot of interest in that across the UK, and we'll all be learning together, and then trying to introduce some new services and commissioning models to really support and embed independent prescribing into the roles of pharmacists in the different sectors. The second area is really building on the work that we have done on our efficiency program and keeping our impact, I suppose, very high in terms of keeping attention on the impact that we can make. We are just about to go out to publish for consultation a new valuing medicine strategy in Northern Ireland. And this is really to build on the work we've done previously, to continue a focus on cost effectiveness, but to also place a new focus on the need for us to have much more environmental awareness around our medicines, to vastly improve how we use data in relation to medicines, and also look for the first time in a while at some of our supply models and their cost effectiveness and efficiency. So look out for that in the next couple of weeks. And the third area that we'll say that is our plan to do next year, and that is to revisit hospital pharmacy practice and clinical pharmacy practice in that setting. We haven't done that for a few years, and in Northern Ireland, all of our hospitals by the middle of 2025 will have implemented the EPIC system. And I think that gives us a tremendous opportunity to really think about clinical pharmacy in a truly digital age here in Northern Ireland. So that's something we will be undertaking in 2025.
Mm-hmm. And finally, do you have a closing message for those who are perhaps less far along the road than you are?
I suppose my message is Northern Ireland is a small country and there's a small number of us involved in really trying to affect change. So I think that what we do here is very, very translatable to lots and lots of other countries of different sizes. And we have had to work incrementally and we've had to build over time. And so things don't happen overnight. But I have a couple of thoughts about what advice I could give to people who are interested. And I suppose the first one is really engage with stakeholders and to do that early on and continuously and to really go out to get buy-in for what you want to achieve from all parties and be clear what you want to achieve, but also in working with stakeholders, work with the willing first because that will keep and preserve your energy. And that has paid off a lot for us. And you'll find there are a lot of people who are willing to work with us. The second area is to focus on small wins and measure your impact ruthlessly. And remember that your impact has got to be of value and importance to the stakeholders who will ultimately make decisions about investing in your roles or your new services. Thirdly, prioritize, have a plan, and focus on leadership and your leadership and the leadership within your system. And finally, I would say always, always stay patient-centered. That is what we are about, and that provides the strong foundation for everything that we aim to do in pharmacy.
Professor Cathy Harrison, thank you very much for talking to us about this important topic. That really has been terrifically interesting and inspiring. For more information about the work described in this interview, please visit the website using the links in the description, and be sure to subscribe for more news, videos, journals, and podcasts. For updates straight to your inbox, please follow the links below. And thanks for watching.